we are going to focus our slide, which is already prepared. We have prepared the slide and focusing it. So put under the microscope on the stage and fix this. This is the low power objective lens. So objective lens 10 and eyepiece is 10. So total 10 into 10 is equal to 100x. Now I am going to focus the cell. So let's see. Yeah, see, these are actually cells. These small things are actually cells. So RBC number is very much high here. Obviously platelet will be 1.5 to 4 lakhs, 4 lakhs 8 million, and this is lakhs, and WC 4 to 11,000 per cubic millimeter blood. So it's clear the maximum number will be the RBC 4. RBC size is 10.2 micron, platelet size is 2 to 4 micron, and WC size is 10 to 12 or 10 to 14. In this slide we have everything: RBC, WC and platelet. So we will see so many RBCs, and in between RBC you will see so 1 or 2 WC. So we will get hundreds of RBC in one slide and 1 or 2 WC of different. But as magnification is very low, so size is very smaller, I am going to change the magnification power now. It's around 40x high power. So first is low power. We should see the cell is distribution is okay or not. Then high power, and then finally high power is called 40x objective lens power, and obviously this is 10x always there. So 40 into 10, 400x total magnification will be. Then finally we use wide immersion, which is for 100x objective lens, and that will be 100 into 10. So total magnification will be 1000. Because we are using the 40x objective lens, so diaphragm should be mid open usually, and condenser should be always in the mid position, not so high or not so low. So see under the 40x microscope. So it's, yeah, cells are visible. So I am putting the oil here on the glass slide. So oil immersion will almost touch the glass slide, and whatever gap we left, few millimeter, that gap will be around 2 millimeter, and that gap will be filled by oil. Yes, so this is the 100x, or we can say oil immersion, 100x objective lens. So total magnification is 1000x magnification, and here we can see the cells. So this is actually lymphocyte, and these all cells are actually RBCs. These are RBC. Till now we have prepared the slide and stained it, and then after washing we have focused under the microscope. So if we focus on the low power, so suppose 10x objective lens, so total magnification will be 100. Total magnification into 10x into 10x will be 100x. So your cell will look like this. These are actually white blood cells, okay, WBCs, and other are actually RBC. This red color is RBC. When we'll focus under the 40x or high power objective lens, so 40 into 10, so total magnification will be 400x. So your cell will look like this. And now finally we can focus into the 100x objective lens, so 100 into 10, so total magnification will be 1000x. We have neutrophil, then eosinophil, basophil, lymphocyte and monocyte. So these are the white blood cells: neutrophil, eosinophil, basophil, lymphocyte and monocyte. So we have to first identify these cells, and then we can be able to count that cell. So let's see how we can identify the cell. Actual picture of the microscope view. So this is a one slide. This is a view of one slide. So slide, where is the slide? This is your slide, and you focus suppose this area, and this area will look like this. So let me explain. So this is the RBC actually, this is RBC, and these all are actually RBCs. Okay, so now we are not going to count the RBC, we are going to count WBC. To count WBC, different WBC, we should understand what is this WBC. We know the RBC number is very much high, so background you will see the RBC, and size of RBC is around 7.2 or 7.4 micrometer, roughly around 7.25 micrometer. So we will compare the cell size based on the RBC size. So we will consider the RBC size around 7 to 7.4 micron, and based on that we will compare the background WBC. So first thing, I want to discuss about the lymphocyte. So lymphocyte is actually two lymphocyte we have, a small and large. A small lymphocyte will actually look like this, around 7 to 8 micrometer, which is roughly similar to that of RBC. And the thing is that this is dark blue in color. Yes, you can see this is actually a small lymphocyte, dark blue in color, and cytoplasm is completely filled. There is no space here, and sometime you will see that some slight space you may see a small lymphocyte. And whatever the large lymphocyte, will see slightly bigger, 8 to 10 micrometer or 10 to 12 micrometer. So suppose this is the large lymphocyte and cytoplasm is 80-20. So this is the nucleus size and this is the cytoplasm size 80-20, and size will be around 10 to 12 micrometer. So 7 to 10 micrometer. Lymphocyte will cover whole the cytoplasm. Nucleus will cover whole the cytoplasm. You will not see any clear cytoplasm, or sometimes you will say the margin of the cytoplasm. But here in case of large lymphocyte, you will just say 80 and 20. So that is the lymphocyte. And what about the monocyte? So monocyte will be actually 14 to 24 micrometer or 21 micrometer. Suppose 2 to 3 times of RBC. Suppose this size of RBC, and you will see the monocyte. Monocyte size will be actually 2 to 3 times of RBC, and nucleus cytoplasm ratio will be around 50-50. This clear cytoplasm will be 50% and nucleus will be 50%. So that is actually monocyte. So now we can identify two cells, one is lymphocyte and monocyte. A small lymphocyte, we have 7 to 20 micrometer, which is similar to that of RBC, because RBC size is around 7.2 to 7.4 micrometer, and lymphocyte size will be, a small lymphocyte size will be the same, but RBC will be slightly pink in color. Disc cell uniform size, background large in number, and lymphocyte will be small in number, few lymphocyte you will get, and that will be similar to that of RBC size, but nucleus will cover whole the cytoplasm and dark purple in color. And clear cytoplasm sometimes will say slight in the margin. In compared to that, large lymphocyte will be slightly bigger, 10 to 14 micrometer, and clear cytoplasm and nucleus ratio will be 80-20. So nucleus will be 80% and cytoplasm will be around 20%, roughly around. Same thing, sometimes there will be confusion with the large lymphocyte and monocyte. Why? Because large lymphocyte size 10 to 14 micrometer and monocyte size is also 14 to 24 micrometer. So in that case, sometimes confusion will be there. So how will you clear? Similar type, agranular cell, lymphocyte is agranular and monocyte is also agranular, but size is 14 to 24 micrometer. But nucleus and cytoplasm ratio is roughly around 50-50, 50% nucleus and 50% cytoplasm, clear cytoplasm will get. So that is the differentiating point. So till now we studied the lymphocyte and monocyte, how to identify it, and then we'll move to the next slide. Here now you try to identify which cell is it. What is this cell? Yes, obviously anyone can say this is neutrophil. No, this is not neutrophil, this is the lymphocyte. And which lymphocyte? Is the small lymphocyte. So this is the small lymphocyte, but we will just count as a lymphocyte. And what may be this cell? This is actually large lymphocyte. So again we will count as a lymphocyte, but this is a large lymphocyte actually. This is a small lymphocyte and this is a large lymphocyte. Clear? See, this is the small lymphocyte. Again try to see, this is the size of RBC. So this is actually 2 RBC, maybe this is the size of RBC. This is actually RBC. This, suppose this is 1 RBC and this is the 1 lymphocyte. So size is almost similar, and slight, this is cytoplasm is here, clear cytoplasm. So this is actually a small lymphocyte and this is the size of RBC. So these are actually overlapping RBC maybe, and this is actually large lymphocyte. This cytoplasm is around 80% and 20+% is clear, 20% this is the clear cytoplasm, and this is the nucleus. I am cleaning it. See, yes, this is the actually large lymphocyte and this is the small lymphocyte. Here we kill it. Monocyte we can show you. This is again, which cell is there? This is the large lymphocyte, this is the small lymphocyte, and see, monocyte is here. Yes, this is the monocyte. Can we see? Yes. So nucleus is here, you can say 50% is nucleus and cytoplasm is around 50%. And see the RBC size. This is the RBC size. So this is 3 times of RBC. This is the RBC, this is RBC, this is RBC. 2 RBCs are overlapping. See this is 2 RBC. This is not the single RBC. 1 RBC here, overlapping RBC. Here also we have overlapping RBC. You have to understand. This is a single RBC. This is the 1, 2, 3, 4. So like that. So overlapping 1, 2, 3, 4, 5. Okay. So just see how it's overlapping. Yes. See here. This is the which cell? Monocyte. Clear? And other cells are lymphocytes. So up to now I am 100% sure that you are clear about this is the large lymphocyte, because cytoplasm is 20% and this is a small lymphocyte. Okay. So first thing is clear up to now based on the size. So based on the size and granules. So, and not only granules but nucleus size, nucleus cytoplasm ratio. We understood lymphocyte and monocyte. Why the size? So different type of size we have compared to the RBC. So lymphocyte, a small lymphocyte and large lymphocyte we can compare. Then monocyte we can compare with the size. Then granules. Obviously lymphocyte and monocyte both are a granular cell, so there will be no granules at all present. Then nucleus and nucleus cytoplasm ratio. So nucleus, obviously lymphocyte has complete, a small lymphocyte has a full nucleus, no cytoplasm. Large lymphocyte has 50% nucleus and cytoplasm is 20%. Obviously you have to consider size of the cell and then nucleus, cytoplasm and granules, everything. And then monocyte we have nucleus 50% and cytoplasm will be 50%. Up to now I am 100% sure that you are clear with the lymphocyte and monocyte. Now let's move for the other cells. To make it more clear, this is actually basophil. I will again come to this slide and explaining. So let's move towards the other slide and let's see what is going on. So here, yes, here this is a this is obviously, you know what is this cell, what is this cell. This is actually lymphocyte. Okay. Now this is a large lymphocyte, obviously you are clear. But here, what is this? This is actually neutrophil. Why neutrophil? Size obviously is similar to that of RBC. Again granules 1, 2, 3 lobes. So we have the 3 lobes is here. So we have 3 lobes here, and see platelets are also here. So in this slide everything is clear. These are RBC, these are WBCs, and these are platelet actually. This dot are platelet actually. So now we can see here in this slide we have one cell which is bigger than that of RBC, 3 lobes and granules. This is not that clear, but still we have granules. You will see the microscope while using fine adjustment, you will get the fine dusty granules also. So this is a neutrophil. Again I am moving to, this is also neutrophil actually. So multi-lobe cell membrane is ruptured, but it may not be clear. Here also is neutrophil. So this is the clear picture of neutrophil. See, this cell is around and nucleus or lobes are actually overlapping and dust granules. See, this is also neutrophil actually. This is also neutrophil. 1, 2, 3 lobes. This is also neutrophil. 1, 2, 3, 4. This is also actually neutrophil. 1, 2, 3 or 4 lobes actually there. This is also neutrophil. 1, 2, 3 lobes. This is also neutrophil. 1, 2, 3 at least. So when you use the fine adjustment, picture will be more clear. So up to now I think it's clear. So again see the picture. These are neutrophil, 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 neutrophil. This is neutrophil, 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 lymphocyte, 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 neutrophil. This is the lymphocyte, large lymphocyte. So how we can count it? How we can count it? That is important. So counting, and we have to make a box of 10 into 10. So I will show you the box. So 10 like that. You can make the box of 10 into 10, 100 cell. So I have already made this box. So this is the box, and suppose you have focused this first cell. So this is the one cell, first cell. So I have seen this is again neutrophil, this is again neutrophil, this is neutrophil, 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 and neutrophil. So what we can do? So focus is there. So first we'll write N, 2, 3, 4, 5, 6, 7, 8. So N. So again n, then again n, 1 2 3 4 5 6 7 8, 1 2 5 6 7 8 neutrophil. Okay, so now what we can do, we will focus to the another slide. What we can do, we can focus to another slide. Yes, so suppose here, so in first slide we got two cell, so we have to focus. Suppose this is your slide and you focus this area and this area is looking like this. What we can do, how we can count it? So first we got neutrophil, so I will write neutrophil. This second cell is lymphocyte. We don't have to write a small or large. Okay, next slide is this one. So how we can focus, we will move our slide and we will focus here after gap, not overlapping. Okay, then suppose this cell is lymphocyte, this is again lymphocyte, then neutrophil, suppose neutrophil and then lymphocyte. So this is lymphocyte. Done. Now we move towards the next slide, or suppose we have counted another slide. Now what we can do, zigzag method we can do, like this, then come down, then again come down, then come down, and like this, zigzag method. So we use zigzag method. So we are going toward this side, and then we'll go down and down. We can go now this side, and suppose slide is like this big, then we can go like this, then this, we can move like this. This is zigzag pattern. And suppose this is the next slide. So I got here one cell, this is one cell. Suppose this is a lymphocyte, then again no slide cell is there. Next focus area, suppose this is the next focus area, or this is this focus area. Okay, and I am getting here. So 1 2 neutrophil, then again neutrophil, then neutrophil. So 1 2 3 4 5 and 6, like that we have to complete all the counting. So same time, so neutrophil, lymphocyte, neutrophil, monocyte, basophil, lymphocyte, whatever you are getting, monocyte, lymphocyte, neutrophil, and this is the 10 1 2. Suppose I am counting. So this is the 1 2 3 4 5 6 7 8 9 10, 1 2 3 4 5 6 7 8 9 10. So 10 into 10, so total 100. So when you fill this all the slide, all the counting, you will fill this up to this, and then 100 is over, so total is 100. So now we just write neutrophil, lymphocyte, neutrophil, eosinophil, basophil, and monocyte. And now you have just to count. Suppose neutrophil, you are getting total count is 60 or 62, so your percentage will be 62%. Lymphocyte is suppose 28, then it will be, or suppose 38, so it will be 100% actually, or suppose 32%, so whatever. Then eosinophil suppose 2% or 4%, basophil 1%, monocyte 0%, whatever. So that is actually percentage, and then we have to compare with the normal percentage. So now we should know what is the normal percentage. Neutrophil is actually 50 to 70%, eosinophil 1 to 4%, then we have basophil is actually less than 1%, so it's maximum 0 to 1%, we can say 0 to 1% sometime. Okay, then monocyte is 2 to 8%. So these are the normal level of this white blood cell. So till now we have discussed preparation of a slide, peripheral blood smear. So we have prepared peripheral blood smear. We have taken a slide and prepared the smear. Then we have stained it. So next thing is staining. So staining, all procedure we have already discussed. So first thing we have give Lisman stain, wait for 2 to 3 minutes, that is for fixation. Then we have add distilled water, wait for 7 to 10 minutes, that is for staining, and then we discard it, wash it under the tap water, and then pink, slight pink in color or pinkish blue in color, and then we can dry it, and then we can see under the microscope. So So microscope, we can screen under the 10x objective lens, then 40x high power, and if everything is okay, then we can go for 100x. That is called oil immersion. Which oil we can use? We can use cedar wood oil, or if cedar wood oil is not available, then we can use liquid paraffin, or we can also use glycerin and liquid paraffin we can use. So these things we can use, but usually we use cedar wood oil. And objective lens almost touching the glass slide. So this is the, suppose this objective lens is almost touching the glass slide, almost, and in between we have some cedar wood oil, glycerin, or liquid paraffin. Anything we can use. Why? Because refractive index of these oils almost similar to that of glass. So light will directly pass to the from here. Light will go directly to the objective lens, and we can see clearly. If light will scatter, if then it is very difficult to see the picture. Okay. So after staining, we can count it, make a box. First, for that we have to identify it. So we'll focus it and then identify the cell, different cells, and then we can count it, making the box, and then we can calculate the percentage, neutrophil, eosinophil, basophil, and then we should know the normal percentage of neutrophil, then eosinophil, basophil, and we'll compare. If count is more, suppose neutrophil. So neutrophil count is normally 50 to 70%. If count is more than 70%, then you can say neutrophilia. And if count is less than 50%, then you can neutropenia. Then eosinophil count. If count is increased than normal level, then eosinophilia, and then less is called eosinopenia. So eosinophilia, eosinopenia. Uh, Basophilia is there, but basopenia is not there because 0 is also considered as a normal. So basophilia only will get if count is more than 1%. Okay. Then lymphocytosis, if count of lymphocyte is increased, and then if less than, then lymphopenia. Then monocyte increased number more than 8%, then called monocytosis. Neutrophil normally 50 to 70%. If more than that, neutrophilia. If more than that, and if less than that, then you can say neutropenia. Then eosinophil count is normal 1 to 4%. If more than that 4%, then we can say eosinophilia. Eosinophilia. If less than that, then can eosinopenia. Then basophil is 0 to 1%. Basophilia, if count is more, count is less is not possible because 0 is the normal. So only basophilia if count is more than that. Then we can say lymphocyte 20 to 40% or 45%. Sometimes we can consider normal. So if more than that, then you can lymphocytosis. If less than that, then lymphopenia. Then we have monocyte, then 2 to 8%. If count is more than that, then monocytosis. Most important function of these cells. So first we'll discuss about the neutrophil. Basic function is actually phagocytosis. Phagocytosis means engulfment of foreign particles. So enter inside the body of blood. Then this neutrophil is the first line defense mechanism. Immediately after infection, neutrophil first 24 to 48 hours, neutrophil will be highly active and number will increase because of the release of neutrophil from the bone marrow from circulation. So that particular area, infected area, will be rich of neutrophil, and neutrophil will try to manage that infection or any type of foreign particle or phagocytosis of that particle. So that first line defense against bacterial infection, mainly about the bacterial infection. So any type of bacterial infection, neutrophil count will be immediately increased. This is the first line defense mechanism of our body. And what is the role? Role of neutrophil is the phagocytosis, by which neutrophil will try to control infection. And as neutrophil contain some pyrogen during the neutrophil action, so they will release a pyrogen, and because of that there is a chance of increasing the body temperature. Neutrophil may be responsible for febrile response. Then second one, Second thing is eosinophil. So now we are going to talk about the eosinophil. So eosinophil is actually mild phagocytosis. So phagocytosis will be there, but this is mild. Second thing, limit allergic reaction by degrading inflammatory mediator. Eosinophil has another function to limit allergic reaction. Main function of eosinophil is mild phagocytic. Okay, then limit allergic reaction by degrading inflammatory mediator. So what are the inflammatory mediators? We have inflammatory mediators like histamine, and we can say bradykinin. So what eosinophil will do? Eosinophil will actually degrade this breakdown of histamine and bradykinin. So breakdown of histamine and bradykinin will lead to less type of allergic reaction, because if histamine is more, then it will produce allergic reaction. Bradykinin is more, some allergic response will be produced. And what is the function of eosinophil? Eosinophil number will increase, and eosinophil will actually degrade or destroy this histamine and bradykinin, and number of histamine and bradykinin will decrease. So response, allergic response will be less. So because of this function, eosinophil actually limit the allergic reaction. Then it also provides local mucosal immunity. Local mucosal immunity. So we have three functions. One is mild phagocytic, then limit allergic reaction by degrading histamine and bradykinin, or you can say any type of allergic mediator, degrade the allergic mediator. Then second one is local mucosal immunity for her. Now we'll discuss about the basophil. So basophil, so it's also mild. Let me do it. Okay, so mild phagocytic, obviously. Then next thing is release of histamine. So it will also histamine. Here we can see eosinophil actually degrade the histamine, and here liberate. Basic function of basophil is to release histamine, and eosinophilic chemotactic factor of anaphylaxis will be released, and they will produce what type of reaction? Skin reaction, or you can say allergic reaction to skin. This is also allergy and anaphylaxis. So again, I am discussing about the basophil. So basophil is mild phagocytic. Normal percentage is 0 to 1%. If number is more, basophil. So basophil is a mild phagocytosis. Okay, then basophil also release some chemical that is called histamine, and then eosinophil chemotactic factor of anaphylaxis, and this actually going to produce allergic manifestation of like skin reaction to anaphylaxis, and it also contain heparin, and heparin we know anticoagulant. We will talk about the lymphocyte now. So we have already heard about B lymphocyte and T lymphocyte. B and T lymphocyte. So obviously up to now you understood that B lymphocyte and T lymphocyte is going to produce antibodies, a specific antibody. So these all white blood cells are actually protected to body, but first line defense is actually neutrophil, which is immediately after any foreign particle will enter or any bacteria or pathogen will enter inside our body. Then now we are going to learn about lymphocyte, which is actually B lymphocyte and T lymphocyte, which is produced. So B lymphocyte is going to produce antibody, and T lymphocyte is a helper cell, which is going to recognize any pathogen or foreign particle in our body. T lymphocyte is going to present that particle antigen to B lymphocyte, and B lymphocyte is going to produce a specific type of antibody against that antigen. Till now, we understood the B lymphocyte and T lymphocyte will produce antibody and protect our body, but it will take some time, 2 to 4 weeks or maybe more than that. Now, monocyte is the last cell. So monocyte is going to active phagocytosis. Active phagocytosis. Monocyte is the, when monocyte remain in the blood, then it's called monocyte. When monocyte will tissue space, then it will macrophage. So the same thing. And So this is the second line of defense. So first neutrophil will come, and then if neutrophil is not going to work, first line defense is actually neutrophil, and if first line defense will fail, then other cell will come, and other cell, if we'll talk about the monocyte, the monocyte will be the act as a second line defense. And obviously phagocytosis, active phagocytosis is the function of monocyte. And if entering the tissue space, they need to call tissue macrophage, or you can say macrophage, and their life will increase. So in the blood, lifespan is very less, few days, and in case of tissue space, life will increase. And then this is the most important thing in our body to kill tumor cells. Tumor cells, kill tumor cells. Act as a second line defense of our body. When neutrophil will fail to prevent infection, then other particle and other mechanism will come like monocyte, and if not, monocyte is not going to work, then obviously lymphocyte will work. T lymphocyte, V lymphocyte, antibody will be produced. Precautions. So what precaution we can take? So first thing, we should prepare a ideal blood film. So we should know what are the ideal blood film, all the points. We should know transect, free from vacuoles, neither too thick or thin. So that basic thing. All the margins should be free, no serration, no vacuoles. These basic things. 2/3 or more, 3/4 must be covered, slide, and thickness should be uniform. So these are the basic thing, and then we have to stain and prepare 2 to 3 slide in one go, and then screen it, and whichever slide is better, so that slide we can focus under the oil immersion, or you can say 100x, and then we can see, identify the cell, and then we can count it. Precaution, all the precaution we should maintain to make a ideal blood film, like slide should be clean thoroughly with soap and water, and then over the film, then glass spreader, margin should be a smooth spreader, then angle should be 45-degree during the spreading. Then you should make 2 3 blood film in one go, because if one is not good, then second one you can see. Then timing is must, so first 2 to 3 minutes is for fixation time, then 7 to 10 minutes, next 7 to 10 minutes after adding distilled is the staining time. So then before even putting the stain, we must check the your blood film should be dry. And so first prepare, stain it, and then you can preserve that slide for longer period, even months you can preserve. First skin under the low power microscope, and then we'll go further. If slide is good and uniformly cells are uniformly distributed, then we can go for the oil immersion and count it. Preparation of peripheral blood film and DLC. So we have already discussed about the DLC, differential leukocyte count. So we have differential leukocyte means white blood cell. But what are the other uses of peripheral blood film? We have already discussed about the other than DLC. Anemia, different type of anemia. We will get idea about the anemia, different type of anemia. So it may be microcytic, hypochromic, or microcytic, normochromic, or we can say macrocytic, or even a novel type of RBCs. It may be spherocytosis, sickle cell anemia, or any other type of abnormality. Then we can also know about the platelet count, relative count of platelet. Indirectly, we can count comparative number with the RBC. The response of any chemotherapy on the RBCs. So then we can cancer cells, different type of cancer cell we can detect, blood cancer especially. It's now about the what are the things if suppose neutrophil count is increased. So it may be physiological or pathological. So all the count we have to divide into two things: physiological. After injection of epinephrine. So in case of any treatment, during any treatment, if you inject the epinephrine to a person, and after that you will collect the sample, then you will get the higher count. So that doesn't mean that some problem is there. Then exercise. So after exercise, even after see, then menstruation, then lactation, pathological condition like any pyogenic infection. Pyogenic infection means any type of bacterial infection which generate pus, separate after cut or any injury, or any type of respiratory or respiratory tract infection, tonsillitis, the count will increase. So any type of acute infection, burns, hemorrhage, surgery, newborn babies, the count is higher. So these are the basic thing. If you are doing exercise or any emotional excitement, epinephrine injection, exercise, excitement, pregnancy, menstruation, lactation, newborn babies. So count is higher. So in pathological condition, acute infection like tonsillitis, sepsis, pneumonia. So sepsis, pneumonia, skin infection or acute infection. So any type of tonsillitis, suppose a count of neutrophil will increase. So with clinical history and examination, if you see the DLC, then it will give you an idea. And with the same time, if you do the TLC count, so that will give you more better picture. So here we are clear. If neutrophil count is 50 to 70%, that is normal. If count is more than that, then we can say what may be condition. This count is increased because of the physiological condition, like normal condition, like epinephrine injection, exercise, excitement, pregnancy, menstruation, lactation, and newborn. So these things we have to consider. If not, then we have to think about the paragenic infection, like any type of acute infection like tonsillitis, sepsis, pneumonia, skin infection, even hemorrhage, burn, and even post-surgery. The count may be increased. We have already talked about the neutrophilia. So what about the neutropenia if count is less? So let's talk about the neutropenia. Neutrophil count is less. So malnutrition means protein energy malnutrition. Prolonged and severe malnutrition, in that case there will be decrease in count. Infection like typhoid. So in some infection, usually infection, all type of acute infection or bacterial infection, neutrophil count is increased. But I am talking about now some infection and infestation. In that condition, neutrophil count is decreased. So that is called, first is typhoid. Because of that, total leukocyte count may also decrease because neutrophil is maximum in number. More than 50, 60, 70% of leukocyte is actually neutrophil. Then malaria and Kala-azar. In that condition, your neutrophil count may be decreased. Then aplastic anemia. Then X-ray irradiation. By X-ray, radium, or atomic, any type of irradiation. Exposure. So if person is working in some industry, particular industry where X-ray is exposed or radium is exposed or atomic exposure is there. So in that condition, we have to consider that also. Then some drugs like sulfonamide, epinephrine injection, in which count will increase. But I am talking about the decrease count. So if person is on that person is taking the sulfonamide, some medicines, then chances will be there will decrease in the count. Then aspirin. So sulfonamide, aspirin, and arsenic. So we can say exposure to arsenic may lead to decrease count of neutrophil. So neutropenia may be there. So these are the all about the neutrophil count increase and decrease. Must remember few things. These are the most important thing. Again, these all things are very important actually. Now we are going to talk about the lymphocyte. So it's 20 to 40% normal. So usually in the children, newborn or early childhood, so lymphocyte count is increased. So childhood, lymphocyte count may be higher. Lymphocyte count is pathological condition will increase like most chronic infection. Chronic infection. What is that? Tuberculosis. Chronic infections. So lymphocyte count will increase, and especially in case of tuberculosis. Then obviously leukemia. So lymphocytic leukemia. Lymphocytic leukemias. Then obviously viral infection. Viral infection. Yes, one more important thing is viral infection. Lymphocyte count will increase and neutrophil count will actually decrease in the viral infection. So neutrophil count sometime in viral infection decrease, but at the same time lymphocyte count will increase. Lymphocytosis. Now we are talking about the lymphopenia, decrease count of lymphocyte. So I am talking about this is the increase count. Now I am talking about the decrease count of lymphocyte. So one thing is the ACTH injection. ACTH injection. So ACTH injection, if you give, almost all the count will actually decrease. Neutrophil, lymphocytes. So lymphopenia is actually seen in case of ACTH injection, as well as obviously HIV/AIDS. Then hypoplastic bone marrow. Obviously, bone marrow is depressed. Bone marrow, hypofunction of decreased function of bone marrow. So lymphocytosis, chronic infection, lymphocytic leukemia, viral infection, count will increase, and also in case of whooping cough, whooping whooping cough, this type of thing condition you may get, or sometime the recovery from acute infection, chronic infection like tuberculosis, then lymphocytic leukemia, obviously count will increase, then viral infection, then whooping cough. This type of condition count will increase. Decreased count you will see ACTH injection, AIDS, and bone marrow, hypofunction of bone marrow. So in this condition, your count will be decreased. Now, the next thing we'll discuss about the eosinophil 1 to 4%. So that is the normal count of eosinophil. So eosinophilia we can see in the allergic condition. So example we can say is asthma, increased count, urticaria, tropical eosinophilia, tropical eosinophilia. Then again a round one infestation. So these are the increased count of eosinophilia. Parasitic infestation, you will get increased count of eosinophil. Then we can any other type of skin infection, obviously tropical eosinophilia, skin infection, so urticaria, so skin allergy condition. So any type of allergy condition will get the increased count. So now we set the decrease in count, eosinopenia. So that is called eosinophil count increase, eosinophilia, and penia. So now I'm talking about the penia, eosinopenia. So eosinopenia is mainly seen in the ACTH injection. So if we give the ACTH injection to the person or corticosteroid to the function, in that condition count of eosinophil will decrease. Then Cushing syndrome during the labor also, and burn acute infection, sometime we will see the decrease in eosinophil count. Basophil 0 to 1%. So count is more. Basophilia, polycythemia, smallpox, count will increase, and CML, chronic myeloid leukemia, basophil count will increase. So basophilia, monocyte, so 2 to 8%, that is the normal percent. Monocytosis, we said TB, monocytosis increase count. Syphilis is the condition in which and some leukemias, not all, some type of leukemias you may get increase the count, monocyte count. And another important thing, malaria, Al-Azhar, and CML. Actually leukemia is chronic myeloid leukemia, you can say. Then malaria, Kala. So in this condition, actually neutrophil count is decreased and monocyte count will increase. So that we have to correlate the things. And decrease monocyte count, obviously in hypoplastic bone marrow. So decrease count is hypoplastic bone marrow, or we can say bone marrow is not working properly. So up to this, I think everything is clear. If something is left, we'll discuss in the theory part.